Hello everyone. Today the topic of our discussion is thyroiditis. In this we will study the different types of thyroiditis. We'll study briefly about their clinical features, their pathogenesis. So coming to the thyroiditis definition, it is the inflammation of thyroid gland that can present in acute mode, subacute or as a chronic presentation. The classification includes Hashimoto's thyroiditis, that is a prototype of autoimmune thyroiditis. And then the second category includes subacute thyroiditis, also known as Granulomatous and Quervin thyroiditis as well. The third one is subacute lymphocytic thyroiditis. And the fourth one, which is a bit uncommon, is the chronic fibrosing thyroiditis, that is known as Riedel's thyroiditis. So Hashimoto's thyroiditis is pretty common thyroiditis, and it is one of the most common cause of hypothyroidism in many of the countries. Also, in the non-endemic areas, it is quite common cause of goiter. It is characterized by gradual thyroid failure. So here the pathogenesis lies in autoimmune destruction of thyroid gland. So initially there may be transient thyrotoxicosis due to destruction and transient increased release of thyroid hormones, but subsequently as the destruction uh, overwhelms, the destruction proceeds, then there is decreased level of thyroid hormones. So it is a classical presentation of hypothyroidism. So the disease is quite common in women, as seen in other autoimmune diseases as well. And the female preponderance being 10 is to 1 to 20 is to 1. Such a high ratio is there in the favor of females. And classically more seen in the middle-aged female, generally around 40 to 60 year of age group. This is more common. This condition is much more commoner. Classical presentation is moderately enlarged thyroid, and it is non-tender. Genetics include various genetic mutations like CTLA4 and PTPN22 gene that regulates the cytotoxic T lymphocyte function. It is also associated with HLA-DR3 and HLA-DR5 as well. So the pathogenesis of thyroid, Hashimoto's thyroiditis, uh, it reveals that there is autoantibodies against thyroglobulin and thyroid peroxidase that is quite commonly demonstrable in the sera of the patient. So here there is abnormality in the regulatory T cells that causes the destruction of the Hashimoto's, that causes the destruction of thyroid follicles, and there is release of sequestered thyroid antigens that can also bring autoimmune reaction. So when there is sudden release of sequestered thyroid antigen, it can provoke autoimmune reaction. There is increased depletion of thyrocytes by apoptosis process, and there is dense infiltration of thyroid parenchyma by mononuclear cell infiltration, and fibrosis takes place. So initially there is overwhelming lymphocytic infiltrates, and the infiltrate also includes plasma cells, macrophages as well, and subsequently there is dense fibrosis. So here you can see in the picture there is CD8 cytotoxic T cells that is directly involved in causing the cytotoxicity, and CD4 cells also get activated, and the CD4 cells help in antibody dependent cell mediated cytotoxicity. It causes the plasma cell to produce various antibodies against thyroglobulin and thyroid peroxidase. Now, one of the important complication of Hashimoto's thyroiditis is lymphoma of thyroid gland. Now, this lymphoma is usually a B cell type. It could be either a diffuse B cell lymphoma, or it could be extranodal marginal zone B cell lymphoma. Both the types of lymphoma, B cell lymphomas, are seen in thyroid gland in association with Hashimoto's thyroiditis. And many studies also reveal the association of Hashimoto's thyroiditis with papillary carcinoma, but it has not significant association, and many believe that it is just a concurrent finding. It is not having a very strong association, but definitely there is very high risk of lymphoma that is proven. And coming to the morphology, you can see there is thyroid gland destruction. There is overwhelming infiltration by lymphoid infiltrates, and many a times this lymphoid infiltrates, they aggregate into lymphoid follicles, including the germinal center and mental zone layer. So here you can see the germinal center is characteristically seen, and dense intact lymphoid follicle is being demonstrable over here. And many a times fibrosis is seen secondary to this lymphoid infiltrate, and fibrosis may become extensive sometimes, but usually does not extend beyond the capsule of the gland. And there is also Hürthle cell change. You can see here there is enlarged cytoplasm of these cells. So these are known as Hürthle cells, and these are believed to be swollen due to abundant mitochondria, and because of which these cells are called as Hürthle cells, or sometimes called as oxyphilic cells, and they are having granular, eosinophilic, enlarged cell size and abundant cytoplasm that is very characteristic of Hashimoto's thyroiditis. Now coming to another form of thyroiditis, that is known as subacute thyroiditis, and it is also called as granulomatous and de Quervain thyroiditis as well. So pathogenesis, here it is classically triggered by a viral infection. So most of the patients, they do present with prior upper respiratory infection just before the onset of thyroiditis. That is a typical clinical presentation. So immune response is virus initiated, and usually it is self-limited. It resolves by its own. So there is tender thyroid enlargement, and there is quite discomfort in the thyroid, in the neck area. So here the changes are patchy and depend on the stage of the disease, and the hallmark of the disease is the presence of granulomas. That could be well-formed granulomas, or just it could demonstrate multinuclear giant cells, and scattered epithelioid histocytes may be there. So there may be focal fibrosis, but not very extensive. So here you can see there are presence of mononuclear giant cells. Multinucleated giant cells are there, and these multinucleated giant cells, along with that, there are scattered epithelioid histocytes are there. Usually there is no caseating necrosis, and at times there may be neutrophilic infiltrates may also be seen infiltrating the parenchyma, but the predominant infiltrate in the later stages is this multinucleated giant cells, which are formed by the combining of many of the mononuclear cells. And here you can see that there are fragments of colloid that are seen at places. So the granuloma is characterized by this multinucleated giant cells and occasional epithelioid histocytes. This is the classical feature of de Quervain thyroiditis. The next one is the subacute lymphocytic thyroiditis. Here there is dense lymphocytic infiltrate are seen, and here there is mild hyperthyroidism. There may be goitrous enlargement of the gland as well. It can occur in any of the age, but it is more commonly seen in middle-aged individuals. And here there is classical association with postpartum state. So many a times it is known as postpartum thyroiditis as well. So lymphocytic infiltration of thyroid gland is seen over here also, but you will not see Hürthle cell and fibrotic change as we saw in Hashimoto's thyroiditis. Coming to Riedel's thyroiditis. Now, this Riedel thyroiditis is a rare type of disease. It's a chronic inflammatory disease of thyroid gland that may occur only in thyroid gland, or it may be seen in association with various fibrotic disorders, various diseases having IgG4 producing plasma cells. So it may involve various other organs like pancreas, kidney, liver, and other organs may also be involved by this fibrotic process. So this fibrotic process invades the adjacent structure of neck, and it usually extends beyond the thyroid capsule. It produces various symptoms like airway obstruction, dysphonia, hoarseness is classically seen, and due to thyroid destruction, hypothyroidism, and even parathyroid glands may get destroyed. So hypoparathyroidism is also seen. Dysphagia and even stridor may be seen due to significant tracheal compression. Now coming to this question, you can see that let's have the discussion about some of the questions. So here 37-year-old woman is there, and you can see in this clinical vignette there is not much significant clinical finding apart from some kind of prior history of respiratory tract infection. Physical examination is not very significant. There is feeling of fullness in the anterior neck, and here you can see the serum level of T4 is increased, and then there is a decreased ESH level, and after 2 months it has completely resolved. What could be the diagnosis? So as you all know that this is having an association with upper respiratory tract infection, and then there is transient thyroiditis which has recovered, which has remitted. Now, so what is the diagnosis? So we come to the diagnosis of subacute granulomatous thyroiditis, or viral virus-associated thyroiditis, or de Quervain thyroiditis. That is the answer over here. So coming to the next question. So here you can see there is a 63-year-old female. There is enlargement of thyroid gland, and FNAC study, fine needle aspiration study, reveals lymphocytes, and she undergoes a thyroidectomy specimen, and pathological diagnosis of marginal zone lymphoma is made on biopsy specimen. So what condition is listed in our medical history? So as we all know that Hashimoto's thyroiditis is classically associated with various long-term complications like B-cell lymphoma, which could be marginal zone lymphoma, or it could be diffuse large B-cell lymphoma. So that's why the answer over here is Hashimoto's thyroiditis. So that's all for a brief presentation of thyroiditis. So thank you for your patient listening. Bye-bye.